I'm Gregg Pressman from Einstein Medical Center in Philadelphia. I'm currently at the International Academy of Cardiology World Congress of Heart Disease Sessions for 2018. I've presented on flow dynamics in patients with mitral annular calcification. And we reviewed several studies using three-dimensional echocardiography that showed that the annulus in patients with mitral annular calcification is dilated and hypocontractile. In particular, it contracts less along the anterior-posterior axis than usual. In the normal case, such contraction allows folding across the intercommissural axis, which helps to bring the leaflets together, avoiding regurgitation. In the calcified annulus, there is dilation and loss of that folding, as well as loss of increase in the height of the saddle that forms the mitral annulus. In addition, in segments that are calcified, there is decreased motion of the leaflets, both anterior and posterior, in patients with mitral annular calcification as compared to segments of those leaflets without calcification. We then reviewed flow across the annulus and the leaflets using a technique called particle imaging velocimetry, or PIV. This allows recreation of vortex formation in the ventricle, and we learned that in patients with MAC, that vortex formation is disturbed, and this results in increased energy loss as blood flows across the ventricle as blood flows across the valve and through the ventricle. In addition, if the orifice of the valve is eccentric, which can happen in patients with heavy annular calcification, there's even greater energy loss. So to sum it up, the calcified mitral annulus is dilated and hypocontractile, leaflet motion is reduced, and flow dynamics are altered such that normal vortex formation is disturbed. This leads to increased energy loss as blood transits the left ventricle, and that energy loss can translate into symptoms of shortness of breath and effort intolerance, very commonly present in these patients.